Okay, good evening, everyone. Can everyone hear me okay?
Yes.
Okay, great. Thank you everyone for joining this webinar, Take Control of Your Epilepsy, where all of you are going to hear from Mount Sinai epilepsy experts about different options that you can take to control your seizures beyond medication. My name is Alyssa. I work in the Department of Neurosurgery with Dr. Panov and along with Dr. Singh and Amelia Strahan, who is the epilepsy coordinator for Mount Sinai. We worked with Monteris Medical to put together this webinar. And we're, again, really happy for all of you to join us tonight. So our speakers tonight are going to be Dr. Anuradha Singh. She is a professor of neurology and the director of the Epilepsy Monitoring Unit at the Mount Sinai Hospital, as well as Dr. Fedor Panov. He is the director of the Adult Epilepsy Surgery Program for Mount Sinai. So without further ado, I will hand it over to Dr. Singh to kick off the webinar. And tonight, after hearing from both Dr. Singh and Dr. Panov, you're actually going to hear from a patient who will talk about how he had his seizures controlled without medications. And then at the end, we will leave it open for some Q&A.
Thanks, Alyssa, for arranging this. Thanks for all your support, Amelia and Alicia. So happy to be here. I'll just go over the objectives of the talk today. So we are going to talk about some basics of epilepsy, followed by what do we mean by drug-resistant epilepsy, how do we define it, and what are the different options we have, whether medical or surgical, and what are the pros and cons of each of them. And then we are going to hear from one of our favorite patients, who is one of our epileptologist patient who had surgery at Mount Sinai. And then we're going to happy to entertain your questions. So let's talk some basics about what is a seizure, what is epilepsy, what's the difference between seizure and epilepsy. You can advance the next slide, Alicia. So a seizure is a sudden change in the clinical state of the patient as a result of excessive irritability or excitability in the brain cells, which is called neurons, which are the building blocks of the nervous system. So the manifestation of a seizure can be various. It could be just like somebody is just doing jerking of the arm or the hand, or it could be a sensory seizures that somebody is feeling as if there is a electric sensation, usually not painful, but like tingling, traveling up in the arm. It could be some kind of a psychic phenomena where you feel that you suddenly have some deja vu feelings, you feel that your body is not real, you're not real, or any other sensations like a sudden vertigo. It could be something like a simple panic attack or an anxiety attack like kind of symptoms. Depending on what part of the brain your seizure starts from, the manifestations can be different. And the grading or the intensity of these seizures can be different. It could be something that other people cannot even find it hard to conceptualize that the patient just had a seizure, or it could be very frank, stiffening of the body, convulsions of the body with tongue biting or with, frothing from the mouth, from where you don't even have to read neurology books or any books to think about that maybe this patient just had a seizure. Seizures then can be provoked or it can be unprovoked. So what do I mean by provoked seizures? Provoked seizures is like, suppose I'm a diabetic patient and I took extra insulin and my sugar dropped. I can have what we call a seizure because of low glucose, or it could be abnormal electrolyte imbalance in a patient who has some kind of a kidney disease. So we don't treat those provoked seizures with epilepsy medications. But if there are seizures and somebody had two unprovoked seizures where you could not pinpoint the cause of the seizure, there were no provoking factors, some elements like, somebody got alcohol intoxicated or used some recreational drugs, those are all provoked seizures. Those don't come under the umbrella of the unprovoked seizures. But if somebody had more than two unprovoked seizures and they had to be at least 24 hours apart. So you can have 3 seizures in one day and no seizures, again, that doesn't qualify what we call epilepsy. So if you have more than 2 seizures, they're more than 24 hours apart, or even if you had one unprovoked seizure, but you had abnormal testing, like whatever test we do to diagnose these patients, if you had abnormal testing, that increases your chance of recurrence of seizures in the next 10 years or so, then it is defined as what we call epilepsy. So what causes seizures? As I mentioned, that there are some metabolic causes or some other provoked factors. Like if I go out, I have pain in my back, and if I go out and take a medicine called tramadol, Ultram, that is very notorious to cause seizures. Similarly, there are some other drugs like antibiotics, which can cause seizures too. So, but most of the time, it is hard to pinpoint what caused the seizure. And 50% of the times, we cannot, no matter how hard we try, we cannot find a cause for the seizures. But then there are other times when we see that somebody has unfortunate conditions like cerebral palsy or autism or learning disabilities, or some genetic factors where they were born with some abnormalities in the brain. When the brain cells are laid down, they start at a certain point and they migrate to a different point. And anything can go wrong with that migration process. And those are called malformations of the brain. There can be some genetic causes, some kind of mutations, which can cause seizures or increase your predisposition to have seizures. Trivial head trauma not really causes seizures, but any significant head trauma with complete loss of consciousness with some kind of a hemorrhage in the brain can cause seizures. Any kind of benign or very malignant tumors can cause seizures. Typically, low-grade tumors, which are more benign, cause more intractable epilepsy than the high-grade tumors. But if you have any abnormal blood vessel abnormality, like any other organ, brain also has blood supply. So if there is any abnormality in the vasculature of the brain, like conditions like cavernomas is one, there is another condition called arteriovenous malformations, strokes can cause seizures, and any kind of infection, inflammation, predisposes you to seizures. Any kind of what we call brain infection, encephalitis, or infection of the coverings of the brain called meningitis can predispose you to seizures. So if somebody had one seizure, the chances, this is a question that a lot of patients ask, what are my chances of having another seizure? And that chance really ranges from anywhere from 16% to even 61%. And it all depends on the circumstances surrounding the seizure and whatever the examination, neurological examination or other tests show. Next slide. So when I see a patient first time who have seizures, a good medical history is always important. So finding out from the witnesses who witnessed the seizure, finding out the patient, and I try to split that up into 3 phases. I ask the patient, did you experience an aura or a warning before you lost consciousness or not? Then I ask the family that when he or she lost consciousness, what did they see? What did patient do? What were eyes doing? Where was the head going to? Where were the eyes going to? And then I asked what was the duration of the seizure, and I always try to check that how long it lasted, because if a convulsive seizure where you're shaking, it lasts more than 5 minutes, it's called what we call status epilepticus. But there are times when patients don't see obvious clinical convulsions, but the patients are confused. And if that goes on for more than 10 minutes, that means that it's alarming. So we take a good medical history, then we do a good neurological examination. We see whether we find any abnormality in the examination, and then we run certain tests. So you want to make sure that you do a good quality picture of the brain, which can be a CAT scan, but usually we do an MRI of the brain. In certain conditions, these 2 tests can be complementary, but we usually do a very high resolution MRI of the brain. When we suspect that there is some infection, inflammation, or some kind of a tumor, we also give what we call contrast, but not everybody can have MRI. There are times when patients have pacemakers or defibrillators or some kind of a metallic foreign body like bullet fragments or whatever, then we end up doing just the CAT scan of the brain. And then we also measure the electrical activity of the brain, which is called EEG. There are different ways of doing EEG. You can do just a 20-minute EEG in the clinic, but we want to do tests which measures longer electrical activity. So we do longer EEGs. That can be done at home, but in certain conditions, patients who have very bad seizures, or we are thinking of making changes in their medications, we do what we call a video EEG test in the hospital. So those patients get admitted to what we call an Epilepsy Monitoring Unit, where we try to confirm whether the diagnosis of their epilepsy is correct or incorrect. Because there are times everything that shakes doesn't mean that it is a seizure. So you want to confirm the diagnosis that it's not some kind of a weird sleep disorder or a movement disorder, or God forbid, some kind of a heart problem, like a cardiac arrhythmia, which caused what we call loss of consciousness or syncope, which was misdiagnosed as a seizure. So you want to confirm the diagnosis. Then you want to quantitate that if there is any abnormality on the EEG, we look for what we call epilepsy brainwaves. These are abnormal brainwaves. Now, where are they located? Are they located on the right side of the brain or the left side of the brain? Or how long do they last? How frequently do they occur? That helps you quantify what is going on. That helps you determine if they need any anti-seizure medicine, what dose you are going to use. So there are different types of epilepsy, and these are broad two general classification. One is called focal epilepsy, where the seizure focus starts from part of the brain. Depending on what part it starts, it will have certain kind of manifestations. And depending on how much area it involves, it can spread very quickly, or it can spread very slowly or remain confined to a very focal area. Versus another kind of epilepsy, which is called diffuse or generalized epilepsy, where patients do not even get a chance to experience their aura or the warning, and they go straight into a seizure. There are different seizure types that exist in these two different kinds of epilepsy. And there are times when you get what we call mixed epilepsy, that when we do certain tests, we find that there is evidence of some focality, but there is some evidence that there is concern that there are some generalized epilepsies too. Generalized epilepsy on whole start at an earlier age, and they have a better prognosis, and they are less resistant to medical therapy overall. 90% of the times it's easier to treat that condition. It's also important to know that there are certain generalized epilepsy syndromes where you outgrow epilepsy and you don't have to remain on medications for the rest of your life. But focal epilepsies are more resistant to treatment, and we'll go over the different numbers. So focal epilepsy, usually they have auras. Generalized epilepsies usually don't have auras. Next slide, please. So then is that how common is this condition? A lot of patients ask me that, no, I never had epilepsy when I was born. How come I have epilepsy when I'm 66? Epilepsy can occur at any age. It is more common at extremes of ages. It's more common in infants and children. And it is, again, the second peak that we get is more common after 65 years of age, but it can occur at any age. 1 in 10 people will have at least one seizure, and 1 in 26 people can have what we call epilepsy. So they can occur at any age. The most common cause of, epilepsy in elderly patient is stroke and brain tumors, but brain tumors can occur in adulthood too. There are certain epilepsies, as I mentioned, that outgrow. So there are times when the age of onset when patients started having seizure, what type of seizures they had, and what did we find on the EEG defines what we call an epilepsy syndrome. And that helps us prognosticate, at least give some hope to some of the parents that we think that this epilepsy is more in the benign category, might outgrow and may not need lifelong commitment. But about 70 million people worldwide have epilepsy. And in USA, those numbers are about 3.4 million people. We spend about $4 billion per annum on treating drug-resistant epilepsy, which we are going to define what do we mean by drug-resistant epilepsy. So epilepsy is fourth most common neurological condition, just like you must have heard of headache and strokes and Alzheimer's. So it's a very common condition. And we encounter about 150,000 new cases of epilepsy in the US each year. Next slide, please. There is a little delay from there. So when we encounter epilepsy and more than 2 seizures have happened, then the chances that person will have a third seizure if untreated is close to 80 to 90%. So our first approach is let's do medical therapy. Unless we see something very obvious on the MRI, which we think that should be taken out, because suppose it is a brain tumor or it is a small abnormal blood vessel, something that we can treat in a very non-invasive way, we want to take it out instead of subjecting our patients to the side effects of the medication for the rest of their life. So, then in the medical therapy, it's easier to take a medicine instead of doing some strict diets, but there are about 25, 26 medicines. And since 1990, there has been a surge of newer and newer medications that come out in the market, including marijuana roll or CBD that we call or other newer medications. But they have their side effects. They have their immediate side effects, like I take a new epilepsy medicine, I might have drug rash, like people break rash with aspirin and ibuprofen and other common drugs too. So some allergic reactions can be life-threatening, especially some drugs like lamotrigine or carbamazepine or Tegretol you must have heard of can cause life-threatening rash, thank God rarely. But then they have these common side effects. Patients feel fatigued, patients feel lack of energy. There are certain medications which cause significant weight gain. There are certain medications which cause significant weight loss. Some patients say that they have double vision or dizziness, or they feel this difficulty walking when they take medicines. And it all depends on what dose your doctor is using. Are you on a lower dose and your epilepsy is well controlled, or you're in a very high dose? Are you on 1 medications or are you on 3 medications? So different medications also have different long-term side effects. The drug that we use in the emergency room all the time called Dilantin causes some long-term side effects like cognitive side effects or problems like nerve problems like neuropathy, or some balance problems because it doesn't like certain areas of the brain. It can cause skin problems, and the list goes on and on. There are some medications that we use which require very strict monitoring of the blood levels, also strict monitoring of different routine labs. And one such example is felbamate or felbutol, where you need a strict monitoring because it can shut down all the cell lines of the bone marrow. So if there is a reliable patient who doesn't make it to the medical appointments, there's something that I'm very afraid of using. So some medicines require strict blood monitoring. And the more medicines you take, the additive side effects of all those medications take a toll on you too. So we're always worried about the short-term and the long-term side effects and how the patient is tolerating the medications. And if they are on a low dose, if they are seizure-free, then fine. But if they are struggling with seizures and they are struggling with the side effects, it makes our job really, really difficult. Next slide, please. So then how many people respond to medications? So if I start somebody on 1 medication, there is a good chance that roughly, I would say, rough ballpark, 47 to 50% of the patients will do very well with just 1 medication. Now, what if they fail that first medication? If I introduce a second medication, I'm already nervous in my head because only additional 13% of the patients will become seizure-free. They will become seizure-free after adding the second medication alone or in combination with the first or the second medication. Now, if the 2 medications have failed and they are still struggling with epilepsy, the chances that a third or a 26 newer medication is going to cure their epilepsy is less than 4%. On the other hand, if we figure it out that they are good surgical candidates, if we see something on the brain, if we pinpoint the hotspot where the seizures are coming from, they have anywhere from 50% to even 90% chance of seizure freedom. So we are comparing the number 4% in one digit versus this big number. And there are certain conditions where, there are times when we don't even try medical therapy and we advise surgery right away. So it's about 1/3 of the patients who continue to struggle with epilepsy, continue to struggle with seizures. Next slide, please. And there are different reasons for drug transporter epilepsy. Is it because all these medications have to act in the nervous system? So yes, you are taking it, but the blood has to circulate those medications to the nervous system. So whether it is a genetic tendency that you have resistance to the medicines that you're taking, or brain is finding some resistance and has some kind of a transporter defect where the drug is not reaching where it should go. And that's the most common hypothesis that we talk about is like, why couldn't we win war over tumors? Because the tumor cells are smarter. Similarly, the epileptic cells are smarter. They either try to efflux, means that try to get the medicine out of the brain, but there are other conditions like some inflammations or some infectious diseases where they are very, very resistant to, they get status epilepticus, or they get very prolonged seizures. So there are different genetic factors, depends on what kind of brain tumors, and the list goes on and on. And there are times when you have these resistance to the different ion channels or the receptors where the drug should work, it doesn't work. So next slide, please. Now, what are the different problems with these, if somebody has uncontrolled epilepsy? People take an emotional toll when they deal with the seizures. When you see a teenager coming to your office and feel that as if their world had just stopped because they had one seizure, and when they have this uncertainty that what will be their next 5 years or 10 years going to be, will they be able to finish their college? Will they take any cognitive toll from the seizures? Will they be able to tolerate the medications? There are times when obviously we want children to go on medications because we see some abnormality on the brain MRI or the EEG, but parents are reluctant to subject their patients to the side effects of the medications. People living in suburban areas, they start, showing tears that, I will not be able to drive and will not be able to lead my kid to school or pick up my kid from school. So it takes an emotional toll. I know when I deal with women with epilepsy, they have serious concerns that whether they will be good mothers, they will be able to take care of the newborns the way they had dreamt about, or will they be able to marry? Will they be able to go into a relationship? Will they transmit this epilepsy to their kids? Occupational, opportunities wise, will they settle down with the not so optimal job, or will they be able to reach all their dreams or not? So, and then as I talked about is that, will they be able to tolerate the side effects or not? So there are patients who say, suggest me what else can I do besides taking these medication. I'm taking them, but still struggling with the epilepsy. But there is another thing that I don't bring up with my parents and my families right away, but it's called sudden unexpected death in epilepsy. And it's more common in males. It's more common in people who just slept fine and never woke up. They had a dinner with their family, woke up and were found to be, never woke up and were found to be dead. And it's not that they died because of status epilepticus, not dead because they had an accident, motor vehicle accident during a seizure, or a drowning incident, or a burning or any kind of a major fall and other physical injuries, but like a healthy patient died, and people, they are trying to find out on their autopsies that what went wrong, and they don't find any cause, but whether they choked on themselves, or patients who tend to sleep in the prone position, they are at a higher risk. Patients who have nocturnal seizures, mean only nighttime seizures, and mainly convulsive seizures, they have a higher incidence of what we call SUDEP. So if my patient is not taking the diagnosis seriously, and if they have those particular seizure types, then I start bringing up this topic with them. But there are families who get very annoyed about that. But no doctor ever told me that you can die during an epileptic fit. So next slide, please. So what should we do? When should we consider other options? So the other option is a surgical therapy. And there have been a lot of papers which Dr. Panov is going to discuss in detail also, which have shown that medical therapy versus surgical therapy, and there is no doubt that surgical therapy works in certain patients who are good surgical candidates. So a drug-resistant epilepsy is when you have picked up two appropriately chosen medications, they were appropriately tolerated by the medication, and still they are having seizures, as I mentioned in one of my slides. So if you have tried two anti-seizure medicine, if you're still struggling with these disabling seizures, and you have determined that the diagnosis is correct, and it makes the definition of drug-resistant epilepsy, if there is any MRI abnormality, and your seizure focus can be easily removed without taking any risk, without causing any operative deficit, then it should seriously be considered. And unfortunately, we see a delay of 20 to 30 years before patients reach to the right doctors, like an epileptologist or neurosurgeons who are trained in doing epilepsy surgeries, which is hard to conceptualize even in centers in New York City. So these patients, next slide, please. These patients should have a good medical history. They should be referred to the Epilepsy Monitoring Unit. They should have a proper long-term EEG, like a video EEG. Sometimes it's limited when you do the EEG testing on the scalp. So sometimes you have to put electrodes directly in the deep surface of the brain, which are less invasive brain surgeries. And we should have a good quality MRI. In certain cases, we do even advanced imaging. We try to measure the blood flow in certain parts of the area and see if there is any defect in the blood flow in certain areas that identifies the seizure focus. We check memory in these patients in a very detailed manner, which is called a neuropsychology testing. And then we put all our heads together. We meet as a group of epileptologists, group of neurosurgeons trained in epilepsy, neuropsychologists. We all put together and discuss the case in detail and see what else can we do for these drug-resistant epilepsy. Next slide, please. So at this time, I'm going to stop and ask my dear colleague, Dr. Panov, to discuss some of the least invasive options that we have in terms of surgery. Thank you, everyone.
Thank you so much, Anu, and for an excellent talk. And I want to thank everyone else who has logged on so far. Again, our job is to get the word out, to make sure that everyone who's dealing with epilepsy knows the treatment options. And that's the point of today. And we're really looking forward to your questions as we get towards the end of the talk. Next slide, please. So what we want to do here is we want to take you guys through the options that have existed. Some have existed for the last 50 years and some are the last decade or so. We'll start with a classic one, and that would be the open resection. And as you were following Dr. Singh's talk, you saw that there are conditions where a small portion of the brain is causing these electrical storms. And it's very difficult at times to control it with medication. If that's the case, the workup will allow you and the team that's treating you to figure out if an open resection is a possibility for you. If that portion of the brain is small, easily reachable, and does not change you as a human being, if it is ablated, deactivated, or resected, the best option remains the open resection. Next. So the next bubble that we'd want to discuss is going to be neuromodulation therapies. These options are for patients where the seizures start in an area of the brain that needs to stay there. That's the area of the brain that maintains you the human being that you are. It allows you to remember your relatives or where your keys are. It allows you to move your left hand, allows you to smell. All those areas we call eloquent. If seizures are starting in those areas, we suggest neuromodulation, which means working together with your brain to try to get the seizures to decrease in their frequency and in their severity. Next. And a good option in between is the minimally invasive surgery. For example, if the area of the brain that's causing the seizures and the epilepsy is not needed for function of you as a human being, but is difficult to get to. And then we would offer something like a laser ablation, which we will describe in later slides. Next. So of course, you need to talk to your treatment doctor. And we're always here to help. Feel free to reach out to us. We can suggest people in your area come and see us as well, because different procedures that we'll be discussing will have different outcomes and they'll have different success ranges and percentages. And we always want to tailor this to what it is that you're looking for. If you're looking to decrease only the most severe seizures and the smaller seizures do not bother you as much, well, those could still be dangerous. If that's the goal, that's what the center should achieve for you. And of course, at some point, the treatment team may say, these are the options, these are the percentages, but we don't think anything should be done. And we have to all understand that that's always a possibility in medicine. After this extensive workup, the answer may be we have to continue the medications and we have to try to manage this without surgery. We do have to be ready for an answer like that as well. Next slide. So let's start reviewing those three bubbles, and we'll start with the minimally invasive laser ablation option. So again, as a reminder, if we have pinned down the source of these electrical storms to a small area inside of the brain, and that area is something that you can live without, so what we call non-eloquent, then a possible procedure using robotics allows us to make a small opening in the skull. And it's about the width of a pencil. It's even smaller. It's about only just the pencil lead itself. And through that tiny opening, guided by a robotic system with the patient asleep, we're able to thread a tiny little laser to the area of the brain that needs to be deactivated or ablated. This happens live in the MRI scanner because the MRI machine allows us to see the temperature at every single millimeter of your brain, second to second. The recovery from this procedure is very fast. So once the laser itself has been activated and the ablation has occurred, the laser gets removed. The closure is very quick. We did one of these procedures just a couple days ago, and it's one stitch. And usually the patients will stay in the hospital anywhere from 1 to 2 nights. Next slide. So as we said before, people who should be considered for this do need to have a clearly defined area. And we need to be convinced as a team that that is the area where the seizures originate. If the seizures are wider spread, then ablating just that one area of the brain may not do any good. They, of course, have to be refractory to medications, as Dr. Singh has mentioned. It's a requirement for us to be able to treat. If a medication is working, it may not be worth to do the laser ablation itself, and you may decide to continue taking the medication. And some patients will benefit from a minimally invasive approach. It may be their wish and their selection to try this first. And again, this is all a conversation with your treatment physician to see if the risk and benefit balance is in your favor. Next. The results from this are encouraging, and they continue to improve the more we find out about the seizures, specifically about the treatments, and as we're accumulating more and more patients who have gone through these procedures. So right now, we usually quote the success rate at somewhere between 50 and 60%. Again, remember and compare that to what Dr. Singh mentioned, whereas the chance of you becoming seizure-free with the next seizure medication after 2 is only 4%. So we're talking about a factor jump at least. We also see that in addition to getting rid of the epilepsy, the quality of life of patients improves. And for the percentage of patients who do not have complete seizure freedom after this, the seizures may become less severe, they may become less frequent, and the postictal period when you're recovering from the seizure may be shorter. All those things can still improve the quality of life and the social function of a patient. We do not have to shave the head. The incision itself is very small. And as we mentioned before, the critical care stay and the stay in hospital is small. Because the incision is so small, the post-procedure pain is also minimal. Next. There are a couple caveats to this, since the procedure has to be done inside of the MRI scanner, which is a large magnet. You do have to be able to undergo an MRI. Some patients still have implants in their body that have been done in the early to late 80s that are not MRI compatible. And there are still complications because this is still a surgical procedure. There could be swelling of the brain or the soft tissues, which is treatable. There could be hematoma. You can think of that as a black and blue mark that can form on the surface of the brain or inside of the brain. And some patients will say that there's some headaches that go along with this. Neurological issues are rare. The one that we quote the most for one of these common procedures is called a field cut, which means usually a temporary inability to see out of the top corner of your eye for a time. And memory impairment, depending on where the ablation itself takes place. One of the common places for epilepsy to live is in the memory circuits of the patient. And if we see that the benefit to getting rid of the seizures really outweigh the risks, but there's some potential that the memory can get worse for a time, some patients will decide that that is worth it to get control of their disorder. Next. So the next bubble now is going to be the neuromodulation therapies. So again, if we take a step back, this is for when seizures have been proven to come from an area of your brain that is not resectable and not ablatable. Something that you truly need to keep, something that makes you, you. So in this case, responsive neuromodulation is a device that's implanted in the brain, specifically with a tiny little contact, a lead, in the area where the seizures originate. It waits and listens for the seizures to start, and then it's able to send a small countercurrent to stop those seizures from spreading. Now, again, this is not a cure, although we have had patients, approximately 10% or so, who do very well with these devices. But this is an augmentation. This is an addition to medication to try to get the symptoms under better control. So to do this, what we do here is we remove the portion that should say actually skull. So a little bit of the bone gets removed and replaced by titanium. And that titanium is actually stronger than the skull itself. And that allows the little device to sit just under the skin, flush with the skin itself. So it's really almost impossible to palpate. And the thin wires inside of the brain connect to that device and get tunneled into the skin as well. And the hospital stay is also very short, usually 1 to 2 days. There will be some scarring because the opening is a little bit bigger than it is for laser ablation procedures. And patients are given a remote monitor, laptop, or home usage, and they're able to download off of this device, and they're able to stay in constant communication with their epileptologist and the treatment physician to try to get these seizures better and better. Now, this works over time. It's not something that helps the seizures right away, but we see that with every year of this device being implanted, the outcomes get better and better. Next. So who should be considered for responsive neuromodulation? Again, you do need to have a clearly defined area where the seizures begin. That is important for us to be able to target that spot with the contacts themselves. The seizures have to be not well controlled with medication. And as of right now, the Food and Drug Administration approves this procedure only for those who are 18 years or older. And usually it means that other surgical options have been ruled out. You cannot have a resection and you cannot have an ablation. Next. So these are the outcomes that are quoted in the current literature. And again, thousands of patients have had this done. And the longest trial right now is past 9 years. So we see that 75% at last follow-up have 50% or greater seizure reduction, which is significant. We also see that this positive effect, as we said, increases over time. It seems that the brain is able to learn together with this device to fight the seizures. On average, there's really no adverse effects because this is a neuromodulatory procedure, so nothing is removed or altered without the ability to go back. This device can be turned off or removed if we see that the benefit from it is not significant enough. Next. So again, just to stress, this does not eliminate seizures. It has to wait for a seizure, react to the seizure, and prevent it from spreading. Now, as an aside, we do see that some of these devices over time cause less seizures to happen, and we're trying to find out how and why that happens. we do think that the brain is able to slowly get better and better and use this device as an aid to help fight seizures on its own. There can be some pain in the implantation site. Headaches and unpleasant sensations are usually temporary. And there's a small risk of the surgical part of the procedure itself, which means there's a possibility of infection, bleeding, and a low chance of neurological impairment. The potential problems, as with any technology, can be with the device, where the leads may not work as expected and need to be replaced. And for the majority of patients, this will still be in addition to the medications that they take. But some medications may work better when the device is in place. The typical utilization of this, the battery requires changes about every 2 to 3 years. The new device just came out that actually bumps up that time to about 8 years. Next. Deep brain stimulation is something that has been around longer. We have about 30 years of experience with these devices. And this one is implanted in the chest, just under your collarbone, and is connected to the tiny contacts and wires inside of the brain. And the extension wire itself is tunneled underneath the skin behind your ear to get to the spot just under the collarbone. Again, deep brain stimulation will not cure epilepsy, but it will help manage and control the seizures, decreasing the severity of the events and hopefully the number of the events. So as we said, a small incision will be made either underneath the collarbone or in the abdomen, and the wires will be connected to the sensors inside of the brain. The hospital stay for this procedure is also about 1 to 2 days, and patients are given a small programming device which they can use to adjust the stimulation at home. Just as with responsive neuromodulation, it may take several months to get the best level of treatment going, and you will most likely still be staying on medications while this is happening. Next. So to summarize deep brain stimulation and who should be considered, as we said, we do want to have a good idea where the seizures live inside of your brain to be able to come up with a good target to use deep brain stimulation. The seizures have to be uncontrolled on medication, and you really probably have been ruled out for other surgical potential pathways. As of right now, you should be over 18 years old to be able to get this kind of an implant. Next. But the benefits, again, are significant. About approximately 4 out of 10 patients will experience less seizures, and at 5 years, almost 70% will have reduced seizures. This, again, positively impacts the quality of life. The devices, again, can be turned off or removed. These procedures are reversible, and some of the anti-seizure medications can be reduced over time. As we said, the stimulation settings can be adjusted if we're seeing that there's some side effects from the treatment itself, although that is uncommon. Next. So as we said, the main risk and limitation is this does not eliminate seizures. The seizures will continue, but the device allows them to be less noticeable for you and hopefully to affect your life less. You'll still use medication together with this, and the risks from the surgery, as we discussed for previous ones. Risks from the surgery itself and potential mild side effects from the placement. The replacement of the generators depends on the kind of system. There are now rechargeable and non-rechargeable systems that could potentially increase the battery life. So you may only need a revision every 20 years. Next. Vagal nerve stimulation is another fascinating procedure that is able to help patients. In this case, we're able to use one of the main nerves that connects the brain to the rest of the body called the vagus nerve. And it comes very close to the surface, just on the front portion of the neck, right over here. What we're able to do is in a sleep procedure, we place a small battery, again, under the collarbone, and we open up a little incision in the neck just to get down to that nerve to be able to put the contacts right around that nerve. Vagal nerve stimulation will then send an impulse about every 5 minutes, and it allows to increase the natural fighting force of the brain against seizures themselves. Now, again, it does not cure epilepsy, but together with medications, it can decrease the severity and the frequency of seizures. This is typically a procedure that happens during the day, and you're able to go home the same day. There will be some scarring depending on how your skin heals, but usually the skin in the neck heals very well. And you will be given a little magnet, which you can use if you see a seizure coming on to activate the device. Otherwise, it will fire every 5 minutes. And it will, again, take several weeks to months to get to the best level of stimulation, and you will need regular visits and follow-ups. Next. So here's a quick debrief as to when you would be a candidate for vagal nerve stimulation. Defining the area of the brain here is a little bit less important, and we're able to treat some syndromes where the seizures are more generalized, but it's still a good idea to know where the seizures come from the brain to be able to give a good percentage outcome as to how much vagal nerve stimulation will help. Usually this is done only for patients who are not controlled on medication and cannot have other surgeries. This is approved in pediatric population, so you can be as young as 4 or 5 years old and get this procedure. Next. So the mean seizure reduction is about 50% at 1 year, and that may continue to improve with time. Recovery time after a seizure may be shorter, so we talked about the post-ictal period, how long it takes a person to recover from the seizure they've had. And the stimulation settings, again, can be modified to make sure that you're comfortable with the device. About 70% of the patients will improve their quality of life. And again, this device can be removed if needed, and it's placed as an outpatient procedure. Next. As we said before, right, the limitation is does not truly eliminate the seizures. It's just an adjunct treatment. And it may take a few months to a year before the full results of how this will work for you as a patient are known. This will still be used with seizure medication and has some of the common side effects that any surgery does. Bleeding, infection, a little bit of throat pain, and potential hoarse voice because we're close to the vocal cords. The potential problems with the device can happen, as can with any technology. And the battery life expectancy for this case is around 6 to 11 years. Next. And now we arrive kind of at the end of where we started, right? With the most classic surgery, which has been done for about 70 years. If there is a spot in the brain that does not appear normal and does not do the patient any good, but just causes these electrical storms to start. If it is possible to remove that little area without changing the human being in any way, that probably is the best way to seizure freedom. But it comes with its own risks, and it comes with risks that are slightly higher than the minimally invasive procedures. We do have to shave more hair to be able to get to the correct spot. The incision is made in the scalp, and then a small bone flap of the skull is removed for a time and set off to the side. The needed brain tissue is carefully resected and removed, and hemostasis, meaning making sure that there's no bleeding that's happening afterwards, is achieved. Then the bone flap is placed back, and it's usually attached with tiny little titanium screws and bolts. The hospital stays are a little bit longer, and the headache is a little bit more severe over the first couple of days, but we do keep you in the hospital, and we make sure that's treated before you're able to head home. And we have to watch you for about a week to 2 weeks for postoperative swelling and the pain, which will typically resolve. Next. So who should be considered for a resective surgery? That will be, again, a person whose area of seizure focus, the area where the seizures start from, has been clearly defined. The seizures are not well controlled, and that usually makes you a good candidate. Next. So approximately 70% of patients who get through the workup and have found to have an area like this are seizure-free at 1 year. Studies show that that improves quality of life and social function, and this is probably the most well-studied procedure in epilepsy, specifically in a kind of epilepsy called temporal lobe epilepsy. And that's the area of the brain that's just above your ear. Next. The risks and limitations, again, this is the most invasive of all the options. This is the biggest incision and the greatest, although still manageable risk. The incision usually is behind the hairline, but if somebody is in the surgical field, they'll be able to tell the kind of procedure you probably had by that incision and scar. We do require to shave some hair, although that's usually limited. And the potential complications include the list you guys see here below. The majority of them are temporary and manageable, but it is very important to discuss that with your physician ahead of time so that you can really weigh the risks and the benefits of this procedure. Next. Overall, and this is a great point to take home, no matter what the risks are of a comprehensive epilepsy center treatment, let's say we're talking about a ketogenic diet or a minimally invasive laser ablation, the risks have been decreasing decade after decade as we have been getting to find out more about seizures, where they come from and how they're best treated. A year of dealing with drug-resistant epilepsy puts your risks of some of the things that Dr. Sinha has discussed above any risk from the procedure that you can have. Now, the risk, of course, will vary from each person, and some difficulty after the surgery may happen, but usually those are temporary. The greatest benefit of epilepsy surgery is, of course, having no seizures, But even if you can get to the point where the seizures are easier to manage, or are now easier to manage with medication, or the recovery from seizures is better, some patients will choose that over continuing difficult epilepsy. So as we said before, it's very important to weigh the risks against the possible benefits and to have a good discussion with your treatment physician. Next. So at this point, I think Alyssa is going to introduce one of our favorite patients, Matthew, and we get to talk to him and he'll get to share some of his experience.
Great. Everyone, we have Matt Mann here on the webinar. He underwent a laser ablation last year, and Dr. Singh and Dr. Panov are gonna ask him some questions about his experience, and hopefully it'll be, eye-opening and insightful for everyone to hear directly from a patient.
Thank you so much, Alyssa. Matthew, it's so good to see you. Welcome. Thank you so much for coming to do this.
How's it going? How you guys doing? How's everybody doing?
It's great. And believe me, no matter what we say about this, hearing from someone like you who has gone through this is just night and day for everyone on this phone call. So Anu, if you want to, and then Alyssa, if you can, if you forward just one more slide, because we have, this recently came out on our website about Mr. Mann's procedure and his pathway to this. But Anu, if you want to start with your questions. Oh, I'm sorry, you're still muted.
Sorry. Matt, thanks for being here. Really means.
Of course.
So my understanding is, and correct me if I'm wrong, you experienced your first seizure unfortunately, with the diving accident at the age of 26, back in the summer of 2018. Can you tell us your personal experience, that how did it impact your life or your day-to-day activities?
Well, yeah, I dove into a pool in the shallow end, and I hit my head so hard that the blood was literally rushing down into my eyelids. So I had a concussion, and it was about 2 months later where I suffered my first seizure. And to say it briefly, it literally changed my life. I wasn't the type of person that was afraid of anything. I was very extroverted. I was a class president. I played concerts, shows in front of thousands of people. I led the choir at my church. I was just someone who thrived in the spotlight. And it was like, as soon as this happened, it was a 180-degree turn where I was too afraid to raise my hand in class. And the anxiety and other side effects from both the medication and the seizures were just overwhelming. So we went, through a whole bunch of different medications to try to find something that would work. And eventually I went a year seizure free. And I went on a vacation to California, and I believe I was just overwhelmed in a crowd of it was over 2,000 people. And I had a subclonic aura. And then later that night, I had a full convulsive grand mal seizure in my the Airbnb I was staying at. And I had also suffered a concussion hitting my head during that seizure on a granite countertop. And right after that, after going a year seizure free, I was beginning to have them basically every day and having more grand mal seizures, I would say weekly. So we were bumping the medication up at that point, and it was pretty much doing anything. So Dr. Jate had pretty much diagnosed it as drug-resistant epilepsy. And I, for one, wasn't a big supporter of the side effects of the medication to begin with. So when she had first mentioned surgery, I was, pretty open to it. So I met with Dr. Panov, and the fact that he actually explained everything so in depth, like as he just did, and explained the multiple types of surgeries I could have, and gave me the choice and option of which one I would like to choose, was amazing. And so the fact that I chose the laser ablation surgery because he explained how less invasive it was, and the fact that I was able to leave the hospital the next day after a 7-hour surgery was simply amazing to me. So, that alone can speak speak for the different types of procedures you could get. And like he said, there's slight headaches here and there, but overall, it was a very easy recovery. So,
Thanks for sharing your experience, and thanks for
of
letting me
course.
know what your journey was. So I just wish you all the best, and I hope you continue to enjoy good health and fulfill all your dreams. So my very
I
best.
appreciate it. I appreciate it. Thank you.
Oh, Matt, that's what we want for you, and that's what we want for anyone in our family, in our extended family at Mount Sinai, and anyone that comes through our center. I have a question regarding specifically the anxiety that is always a natural thing whenever you talk about surgery, whenever you talk about undergoing general anesthesia. Can you
Yes.
take us through what you felt were the good ways that you were able to deal with it? Was it additional conversation with doctors? Was it reading up on these things?
Well, yes.
Because go ahead.
Oh, I'm sorry. As I was just saying, you specifically have a very good way of explaining exactly what's going to happen, and comparing and contrasting other different types of procedures that could be done. So when I made that decision for surgery pretty much was already on my mind. The medication, the debilitating effects of the medication, the side effects, that was pushing me towards the surgery anyway. But then when you explain how least invasive, like it wasn't invasive, and it was such an easy thing, uh, it was simple for me. It was a simple choice, and I believe that the EEG was a harder process than the actual laser ablation, and that if I knew about this procedure, or if I knew that my epilepsy was drug resistant earlier, I would have done it years ago, because since then I haven't even had a slight aura, not even a little inkling of a seizure. So it's pretty much like I'm cured,
Listen, it's an amazing thing to hear. And just to catch everyone else up, since we didn't go through the details, so Matthew went through a stereo EEG, which is a minimally invasive diagnostic procedure, but it is tough to get through because you have to stay with us in the hospital until we catch the seizures. And that means for some patients it's a couple days, and for some patients it's a couple weeks. And that can be boring, and that can be anxiety provoking. And I remember we tried to even laugh about this. Anxiety promotes seizures. So we kind of wanted Matthew to stay a little bit anxious, but that was probably the tougher part of it, because for the laser ablation itself, we got you to sleep and we woke you up, and then you were out of the hospital the next day.
Yeah.
So the next one I wanted to ask you is, again, you've been saying that things are different since the ablation itself.
Yes.
If there's anyone on this webinar who's kind of on the other side of this right now, trying to see and feel what it would be like to go through the process, just take us through some of the contrasts in your life between where you were about a year ago and where you are now, what you're able to do,
Well,
what you're able to enjoy.
for one, I wouldn't even be able to be having a conversation live on this webinar right now a year ago. I wouldn't, I had so much anxiety. I couldn't speak in front of a class, much less my church or any type of thing that I've done for the past 20 years. There was so much, I lost friends because I wasn't going out. Losing the ability to drive, like Dr. Singh mentioned earlier, on Long Island, it's life changing, because you can't go to it takes 15 minutes to drive to the grocery store, so everything in your entire life. I had to move back in with my parents because the fact that I couldn't live alone, having epilepsy, and all my seizures were occurring in my sleep. So now, there's so much freedom that I haven't had in so long that I'm beginning to get back. My memory is improving. I can remember people's names and faces now, where before I had to drop out of school because I couldn't keep up with learning, 6 different courses across the semester, and, having seizures during the day, and then having the memory loss from the epilepsy and the side effects from the medication. So now, I feel like a brand new man, and in a few months I'll be able to drive again, which will also, change my life for the better exponentially. Currently taking a course to be an EEG technician because it's just something that I really got interested in from all the EEGs I've had over the course of the past 3 to 4 years. And it's just like, I can finally see the light at the end of the tunnel. Whereas for so long, since the beginning of this epilepsy, since 2018, I definitely did not see hope,
Matthew, it's beyond inspiring to hear this from you. Believe me, in the medical field, we go through day by day. We try to help as many people as we can. There's ups and downs, but a story like yours, I'm sure, will carry both Anu and I through the next year of difficult times. Just knowing that that us together with your help, that we were able to get you better. That's incredible to hear.
No, it's truly a blessing, because I had went to 2 different hospitals before Mount Sinai, and I wasn't being taken care of. And my mother is a nurse and has been working there in the surgical ICU for about 40 years. And it was, providence that I should have been there, and it was almost like as soon as I got there, things just started improving. And with the help of Dr. Jate and her team, you, Dr. Gatan, and everybody, it just was, there were people that I met in December that said they have been looking at my head for 2 years and have known me for years, and I've never even seen them, or, and that was something that was very encouraging to me, that everybody there knows what they're doing. And obviously I'm a testament to that because I'm fixed. That's what I could say right now. I am, like I said, a brand new man.
Again, amazing to hear. And for everyone else on the webinar, this is what we hope for. But if we can help a little bit, and we would have loved to have Matthew here, even if this was not a full success, to share his story and to say that, there is light at the end of the tunnel. Sometimes you have to work at it harder, and sometimes you have to go through additional procedures. But if we can work together to get you better to fight epilepsy, that's going to be the goal of this entire center. Matthew, thank you again so much. What we'll have now is we'll stick around for a little bit, and we'll have Alyssa advance the slides. Because really, the take-home point is we want to share as much of that information with you guys as possible. And sometimes these conversations are anxiety-provoking. We want to try to get them to be as easy and as comfortable as we can. So please ask us questions now, ask us questions via email and phone numbers. Please join us if you can for the next webinar that we'll have. But the main take-home point is that if you have epilepsy and you're still having seizures on medications, it is probably time to figure out what a comprehensive epilepsy center can do. How can we potentially improve your life? And that's that appropriate intervention and the need for more data. So go ahead. Anu, thank you so much. And Alyssa, thank you so much. Matthew, such a pleasure to see you. We'll pass along the best to everyone in the hospital who's still asking about how are you doing, okay?
Thank you. I really appreciate the opportunity to tell my story. And I hope that what I said can encourage others to take the same steps that I did. Because like I said, if I knew about this ahead of time, I would have done it. And because it's literally changed my life for the better. So I appreciate it.
Thank you,
Thank
man.
you for saying.
Thanks,
Thank you.
So guys, with this, we're gonna close. Anu and I will stick around for a little bit if anyone has questions, but we want to thank everyone, including Matthew, for showing up, for sharing this Wednesday evening with us. Again, please reach out if you have any questions as follow-up. We're always here and we're always happy to help.
Yes, thank you again, Dr. Panov and Dr. Singh and Matt, for the amazing information you all shared tonight. If anyone does have questions for Dr. Panov, Dr. Singh, or Matt, feel free to submit them via the chat box and we'll ask them aloud and make sure they're answered. There was actually a question that was submitted prior to the webinar that you guys are okay with me asking. Basically, this person asked if any connection has been found between epilepsy or any of its medications and Sjogren's syndrome, if I'm pronouncing that correctly.
Yeah.
Sjogren's?
Sjogren's, yes. So they just want to know if there's any connection between epilepsy or any of its medications with Sjogren's syndrome.
So Sjogren's syndrome comes under an autoimmune disease which can affect brain as well as the spinal cord. And there are times, it's not very common, but there are times when patients can present with what we call status epilepticus, very difficult to control seizures. And since it is considered an autoimmune disease, the conventional anti-seizure medications that we use, they usually do not break that status. So I had one patient that I saw, remember that you touch her body and she will go into a seizures coming from the left side of the body and was not able to walk because her spinal cord was also affected and lost all memory of even to the extent that she did not even remember that she delivered her second child. And she would say that she had only one child. So she lost the memory around the time she went into status epilepticus. So those are treated with different class of drugs that we use for autoimmune diseases like steroids or immunoglobulins and other, immunomodulator drugs. The conventional anti-seizure medicines don't work for that condition, but autoimmune diseases can cause what we call status epilepticus. Refractory means very hard to treat with the medications.
Anu, and thank you so much for that answer. And I think we take the most pride, myself personally, at admitting when I don't know something. So you saved me on that one. And if there's something that we ever don't know, you can trust us that we're going to look it up and find out the best option for you. And here, Dr. Singh saved me from coming up with the wrong answer.
You're too humble. And
well, guys, so thank you again for everyone for attending. We hope that this will be a recurring event, and we hope that we'll see you guys in a few months, and we'll change up the subjects a little bit. But I feel like Matthew is such an MVP of this talk that we're just going to have to keep on inviting you back, man. Okay?
Definitely. I'll be back as many times as you guys need me.
that's very sweet.
Thank you again.
Thank you, man.
Yeah.
Thank
And
you.
thank you so much to Alyssa as well for organizing, and for the team from Monteris for setting this up. Okay, guys. So from now on, if you do have questions, just please go ahead and send them to us via email or call us by the phone numbers mentioned here. And we'll look forward to seeing everyone next time. Okay?
Thank you, everyone. Good night.